This is Peyton, Callie, and On, live from the PAS podcast recording studio. On this week's episode, we are going to be talking about hospital-acquired pneumonia and its subset, ventilator-acquired pneumonia. We'll be talking about each disease and then doing some compare and contrast at the end. Enjoy! So On, tell me about hospital-acquired pneumonia.
Sure. Hospital-acquired pneumonia, also known as nosocomial pneumonia, is defined according to the American Thoracic Society, as a type of pneumonia that occurs 48 hours or more after hospital admission and is not present at the admission time. Callie, tell me, what causes this?
All right, so hospital-acquired pneumonia is typically caused by bacteria, specifically aerobic gram-negative bacilli such as Pseudomonas aeruginosa, E. coli, Klebsiella pneumoniae, or it is a possibility that it is caused by gram-positive cocci such as Staphylococcus aureus, which includes MRSA. It is important to note that hospitalized patients have a different bacterial flora with different resistance patterns than healthy people in the community, which places them at a higher risk for more severe infections. Now, Peyton, what's the epidemiology?
Yeah, so hospital-acquired pneumonia occurs at a rate of 5 to 10 people per 1,000 hospital admissions, and it is considered the most common cause of hospital-acquired infection in the U.S. Due to improvements in the prevention of urinary tract infections in the hospital-acquired pneumonia and ventilator-associated pneumonia are now the most common nosocomial infections. These infections carry a high burden of mortality and morbidity, despite the uses of preventative measures, advances in diagnostic testing, and potent antimicrobial agents. Hospital-acquired pneumonia extends admission to the hospital by 7 to 11 days on average. On, what are some of the clinical manifestations?
Signs and symptoms may include cough, expectoration, a rise in body temperature, chest pain or dyspnea, asymmetric expansion of the chest, and diminished resonance. But the key findings are dyspnea, productive cough, and fever. Some physical exam findings include agophony, whisper pectoriloquy, crackles or rhonchi, or consolidation. Callie, what diagnostic studies can be done?
So the diagnostic studies that can be done to identify and diagnose hospital-acquired pneumonia are chest x-rays, white blood cell counts with differential, which won't establish a specific diagnosis but can help define the severity of the illness and identify complications, pulse oximetry, a culture of lower respiratory tract sample, a MRSA nasal swab can also be done, and with patients with pleural effusions or a thoracentesis must be considered.
Alveolar shadowing on chest x-ray or CT scan supports the diagnosis. Imaging may demonstrate complicating features like effusion, barotrauma, or cavitation. Chest imaging showing opacity, whether focal or diffuse, is required for diagnosis. A CT scan may be necessary, and an ultrasound may also be considered.
All respiratory tract samples should be sent for microscopic analysis and culture, and some non-invasive methods for sampling include spontaneous expectoration, sputum induction, and nasotracheal suctioning. Callie, tell me about some of the treatment options.
Sure. So to treat this type of pneumonia, initial therapy should be broad-spectrum antibiotics covering Staph, Pseudomonas, and other gram-negative bacilli. And if risk factors for MRSA are present in the patient, an antibiotic active against MRSA must be prescribed. Then, once the causative organism has been identified through diagnostics, the empiric regimen should be narrowed according to the pathogen susceptibility. Now, Peyton will talk about ventilator-associated pneumonia.
So ventilator-associated pneumonia is a subset of hospital-acquired pneumonia that often occurs in intensive care units. This is a lung infection that develops in patients who have been on a mechanical ventilator for at least 48 hours. The etiology of ventilator-associated pneumonia are the same as hospital-acquired pneumonia, such as gram-negative bacilli like Pseudomonas aeruginosa, E. coli, Klebsiella pneumoniae, and some gram-positive cocci, such as Staphylococcus aureus and MRSA. On, what's the epidemiology of ventilator-associated pneumonia?
Approximately 10 to 20% of patients receiving mechanical ventilation for more than 48 hours contract VAP, and over 90% of pneumonia episodes developing in ICU occur in patients who are intubated and mechanically ventilated. 1/2 of all antibiotics prescribed in an ICU are for hospital-acquired pneumonia or ventilator-acquired pneumonia, and approximately 10 to 20% of patients of burn patients especially have inhalational injury, which predisposes to VAP. Callie, what are the clinical manifestations for VAP?
All right, so the clinical manifestations are similar to those of hospital-acquired pneumonia, which include symptoms of cough, discharge from throat and lungs, a rise in body temperature, chest pain, and dyspnea. Signs include fever, tachypnea, consolidations, and/or crackles. Peyton, what are some diagnostic studies that can be done?
Diagnosing VAP requires a high clinical suspicion combined with bedside examination, radiographic examination, and microbiologic analysis of respiratory secretions. All respiratory tract samples should be sent for microscopic analysis and culture.
Sampling the lower airways to get cultures can be done by blind tracheobronchial aspiration, bronchoscopy with bronchoalveolar lavage, or by a protected specimen brush. Callie, what are some treatment plans for this?
So similar to hospital-acquired pneumonia, initial therapy should be antibiotics active against staph, Pseudomonas, and other gram-negative bacilli. And then broad-spectrum antimicrobials should be used initially for patients with risk factors for multi-drug resistant pathogens. And then again, once the causative agent has been identified, the empiric regimen should be narrowed according to the pathogen's susceptibility. Peyton, what are some of the differential diagnoses for hospital-acquired pneumonia and ventilator-associated pneumonia?
Some of the differential diagnoses include Acinetobacter, adenovirus, bacterial sepsis, burn wound infections, colitis, croup, Enterobacter infections, enterococcal infections, and E. coli infections. Will you tell me about the prognosis for these illnesses?
Sure. Mortality is dependent on the severity of illness at the time of diagnosis and the underlying comorbidities a patient might have, like diabetes, COPD, and smoking. Without proper management, the morbidity and mortality from HAP and VAP are high. Younger patients with no additional organ involvement tend to have good prognosis, and the crude mortality for VAP may be as high as 20% to 50%. Now we'll compare and contrast similarities and differences between these two disease states. Callie, what are some of the similarities and differences?
So HAP and VAP present the same, and these patients have similar signs and symptoms, and these two disease states have the same etiology and treatment. Some differences are that VAP is defined as pneumonia occurring more than 48 hours after endotracheal intubation, and HAP is an acute lower respiratory tract infection that is by definition acquired at least 48 hours after admission to the hospital and is not incubating at the time of admission. Essentially, the only difference is how it is acquired and the diagnostic studies used to diagnose.
Finally, we'll discuss some of the patient education strategies. First, we'll educate patients on potential complications such as pulmonary embolisms, empyema, or lung abscesses, or sepsis with multi-organ system failure in bad situations. We'll also educate our patients to wash their hands, wear a mask, and keep the head of the bed at a 30-degree angle while in the hospital, which can reduce the risk of germs from the patient's mouth reaching their lungs. Finally, these patients should get the pneumococcal vaccine and influenza vaccine to protect them against these illnesses. Have a good day!
PAC out.
Bye!